We're all members of the Fistula Committee, and we have probably co-opted Yvonne as well to join us, and hopefully she will join us. But one of the issues that we've had to deal with on the Fistula Committee is really looking at where do we go over the next year and possibly over the next 2 to 3 years. And I'd like to first of all speak to Gill and ask her what her views are on how we can take physiotherapy forward within the Fistula community.
I think there are two goals, in my opinion, and one is to continue to develop the role of physiotherapy in the management of women who've experienced an obstetric fistula, and get the message out there so that if people have fistula services or they're developing them, they're thinking there should be a physiotherapist involved because there is evidence out there about the benefits. And my second, which is quite similar, is again to get the word out there so that if there are physiotherapists working in countries where fistula arises quite often, that they're thinking that they have a role, and also perhaps out more internationally to physiotherapists in countries where there may not be a high incidence of obstetric fistula, but to make them think that perhaps they could lend their skills to, say, training in the countries where it is more prevalent.
So really raise the awareness about the need for physiotherapy and fistula care and make sure it is there.
Yes.
And I think I couldn't agree with you more, because the role, particularly in residual incontinence, is huge. Yvonne, as a midwife and from the Fistula Committee, we would like to know, how do you see how we could improve the situation for our women from an obstetric perspective?
Clearly, there's a multidisciplinary approach to this, and seems there's a gap with nursing and midwifery, and I think it will be really good for midwives and nurses to be involved. I'm sure they could make a great contribution to this cause, which is a very good cause. Whilst we have we don't have many cases of fistulas in the UK, but I think raising awareness and acknowledging that this is a problem would be valuable.
Well, thank you very much, both of you. One of the other areas we've had to deal with at ICS is really we've been asked by a lot of our colleagues in the fistula world in the issues with regards to urinary diversion work, reconstructive urology, and perhaps that's an area we also have to work more closely with our colleagues in. And certainly as part of the work we're doing, we will be running our usual workshop at ICS in Canada this year, and we're also hoping to run a hands-on surgical workshop in July of this year, which is probably going to take place in Nairobi in Kenya. The dates and times and place will be put on the website. We're working closely with our colleagues from Kenya who formed a new treatment network. We're also hoping to work with our colleagues in Ethiopia with regards to how we manage pain better in fistula patients, and we're indeed working with all of our colleagues who wish us to be with them. At ICS, we have a lot of knowledge about how to provide information to patients, and we'll be working with the Publications Committee as to what information will be salient to our patients in those settings and also to our colleagues, and we'll be working more closely at raising the profile of fistula within the ICS community. And perhaps another new area we're going to link it with is female circumcision or female cutting or female genital mutilation, which is another arena that we've been asked to keep an eye on. And as you would be aware from our recent comments on the website, we are quite involved in that area as well. Yvonne, you've worked with female genital mutilation patients in the UK. What do you think their real needs are?
We are doing a lot of work with women who've gone under female genital cutting.
Yes.
There's certainly great need for involvement with ICS, and we would value their contribution and work in collaboration with them.
Yeah. Thank you very much, Yvonne. I think this is a very new area in a sense, but yet a very old area in another sense. And basically in under-resourced settings, there's often a link, although not everybody perceives it to be a direct link. But I do think it's the same issues that give the same problems. It is a question of the socioeconomic status, education, and all the issues that go with the girl generation, as they're now called. What do we do with the young girls and education and training and so on? Jill, do you have any comments on this field? Do you find this is a field that we ought to be involved with as well? In Ethiopia in particular, where your experience is, do you see this at all?
I'm aware that it occurs in Ethiopia. It's, as a visiting physiotherapist, it's not something that I've been directly involved with. One of my other roles is on an executive committee of an international women's health physiotherapy organisation, and we've actually recognised that we term the FGM and obstetric fistula as sort of traumatic pelvic floor issues, and as such we're running a seminar on them at an international conference later this year, because, as you have both mentioned, you know, there are such similarities, links, and certainly the effects that they can have on the pelvic floor, and the resulting dysfunctions are really quite similar.
Are similar. Well, you've heard it here from our two experts. You've heard it from Yvonne, our midwife. You've heard it from Gill, our physiotherapist, that actually this is always going to affect women in some way or another. And although we are speaking at the extremes of the problem, there are lots of other problems before then that a lot of women suffer, and we are working towards helping more women recover from that and recover well. If you'd like any further information about what work we're doing and where we are working, then please look on the ICS website and you'll get as much information as you can from there. And if you'd like to contact us directly, please do as well. Thank you very much.